Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, you can download the PDF of this document down in the description below to follow along and make your own notes. And if you would like to subscribe to the channel or or throw a comment on this video, that would be fantastic and help promote this channel. So let's jump into it. First thing I like to do with ECGs is what I call look at the forest, and the trees of the forest are my QRS complexes. So I'll pick maybe here lead 2, and what I see first glance is that I've got this narrow complex rhythm that seems to be a pretty regular rhythm. You can see I can trace this all the way to the end, and it kind of maintains its pattern. It's got a rate here. If I find a QRS that lands on a solid line, maybe this one of 300, 150, 100, about 75 beats per minute. So that's a nice normal rate. We've got narrow complex QRSs. When I look kind of to just start getting an idea of what's going on with atrial activity in regards to this rhythm, I see that it's got this, it doesn't have a distinct, singular P wave in front of my QRSs. Instead, it's kind of got this back and forth pattern. And so, we might all, be able to kind of see this right out the gate nowadays, but it looks like kind of this, almost like this sawtooth type of pattern. And so got a sawtooth pattern. We know since it's low amplitude that this is atrial activity, because the atria is kind of this thin-walled myocardium. It doesn't produce big deflections. And the rate of these sawtooth pattern waves, you can see, are roughly just under 300 beats per minute, maybe 270 beats per minute in between each of these sawtooth little patterns. And so we know that atrial flutter is defined by an atrial rate somewhere around 250 to 300 beats per minute. And it's a very predictable reentry circuit within the atria, most commonly in the tricuspid annulus. And so this, I would say, would qualify very well for atrial flutter. And so you can look here in V1 and you can really see nice, distinct flutter waves. V1 is a great place for distinct flutter waves. The reason why that's the case for atrial flutter is if you look at this diagram here, atrial flutter on the transverse plane, it occurs around the tricuspid annulus. The tricuspid annulus. And the tricuspid annulus is kind of this reentry pathway. And what happens is you're going to get this reentry around the tricuspid annulus. And so you can see a lot of signals are going towards and away from the chest wall whenever it goes around that tricuspid valve. And so you get these nice, sharp, positive deflections in the tricuspid annulus, which is what we see in V1. And so we have atrial flutter. And what are other kind of data points that make us think that this is atrial flutter? Well, we have a narrow complex QRS. We know that in atrial flutter, it's an atrial arrhythmia. And so as these flutter waves are re-entering here and they're depolarizing with every wave throughout the atria, the AV node is a bystander that will conduct that signal down whenever it repolarizes every time. And so our ventricular conduction should be what is normal baseline for this patient. In this case, it seems to be a narrow complex rhythm. And so let's define kind of what the ventricular response is, right? Because how often is the ventricle conducting these flutter waves? It can't conduct every single one. The AV node would be beating the ventricles at 270 beats per minute if that was the case. Well, if you would like, what we can do is we can kind of guesstimate. We can see, first of all, the atrial rate. So my atrial rate is 270 beats per minute, and my ventricular rate is 75 beats per minute. And if you kind of do some mental math, right, I was just eyeballing these numbers, but if you really do the perfect math, you can see that 75 and 270, it's almost about 1/4 of 270 is 75. So it's almost as if there are 4 flutter waves per 1 QRS if you do the math of 270 and 75. And we can confirm that here. You can see maybe if I look in here in V1, you can see I've got a QRS complex, and then I have 1, 2, 3, 4 flutter waves. Then I have my QRS, and then I've got 1, 2, 3, 4 flutter waves. Then I've got another QRS, and you can see that's the case. 1, 2, 3, 4, and then another. And so I have atrial flutter here with 4 to 1 conduction. 4 atrial flutters per 1 ventricular conduction. So every time 4 flutter waves pass by, that fourth time the AV node's like, okay, I'm ready to pass that signal down. And so you can see that it conducts in a 4 to 1 fashion all throughout this rhythm. So we've got atrial flutter with 4 to 1 conduction. Let's take a look now at our QRS. Let's evaluate the QRS. So now what's happening from the AV node down, right? We know what's happening from the AV node and up. What's happening from the AV node down? We say we have a narrow complex QRS. Let's take a look at the axis of that QRS. It appears that it is maybe isoelectric to a little bit negative in lead 1, perhaps, and positive in my inferior lead. So I would say my QRS axis is maybe a little bit to the right. Maybe we've got some right axis. Let me do it in a different color. Maybe we've got our axis kind of shifted to the right. So we've got some right axis movement here. And what can cause right axis changes? Well, we know maybe right ventricular hypertrophy. I don't see that here. V1 in RVH is going to have a tall R wave. I don't see that, so no RVH. Is there a bundle branch block? No. We have a narrow QRS. I don't see any R primes throughout. But what I do see, and I think this will help kind of explain maybe why that axis is shifted to the right, is that if we kind of skip to our pathological Q waves, we see we've got pathological Q waves in V1, V2, V3, and so we finally get a little bit of an R wave in V4. So I would say that there has been a prior anteroseptal myocardial infarction, right? Some type of infarct of the anteroseptal region, which we know is represented, the septal leads are V1, V2, the anterior leads being V3 and V4, because we've lost a lot of the positive forces going that way. And so that tells me that those anteroseptal tissues are unable to conduct signal really well. That might explain why some of that signal is now kind of biasing the right side or the right ventricle, which is not represented by those leads. And so I think that's probably the case to explain that. Let's briefly take a glance at our QT interval. Maybe I can pick a QRS that this is going to be a little bit hard. These flutter waves are kind of right on the money. And so maybe I can see kind of my T wave here in V5. You can see maybe it ends like right there. And so it looks like it ends at least by the midway point of those R to R. So I think my QT seems to be okay. Last thing we're going to do is we're going to look for our ST changes, see if there's any elevation or depression. There's nothing that sticks out to me, right? We would definitely compare this to a prior ECG if we had one. And so now let's just put this rhythm together. And what do we have? We've got an atrial flutter with 4 to 1 ventricular conduction at a rate of 75 beats per minute. We've got a right axis and what appears to be evidence of a prior anteroseptal MI, evidence by pathological Q waves in the anteroseptal leads. So I hope this helps. If you have any questions, throw them in the comments. Remember, we evaluate an ECG from an anatomical standpoint, not from memorizing, we have to now look at the PR interval. We have to now look at the QRS. So what are those things and why are they can we predict their changes and explain their changes from an anatomical and electrophysiological standpoint? So I hope this helps. We will see you tomorrow and have a great day.